quite a major impact. Our key objective is to share our experiences with you and improve care of our patients. And that's what MotecLife stands for, as you can see, one by one. Movement of all people. Originally it was orthopedic trauma. Now it's concentrating on teaching and training and exchange of ideas, education. We try to be faithful and economical. In these hard times, it's difficult to find money to do anything. We have a leadership that is prepared to listen and adjust according to the difficulties that we face. We have a lot of links that we work with. The World Orthopedic Concern, the Tropical Health and Education Trust in London, the Association of Anesthetists of Great Britain, who have been very helpful to our cause. And I'm sure you hear a lot more about that in the course of the week. Initially, we were supported by the International Organization for Migration. Their support is dwindling, but yet we will just make the most of what they can do. They now have a program that helps people to return to their country, mainly from Holland, not from England. So we are looking for other sources of funds. The national groups that we work with include the Ghana Health Service, the Ghana College of Physicians and Surgeons, and of course we have certain motivating observations that keep us going. We believe that life is not worthwhile unless it's made a positive difference to the people we see or never get to know. It's all about money, but money cannot do everything. The education we're going to have here, the experience we're going to share, can have an impact on people that can save their lives. But I feel strongly, just like Emigwali said, the best investment we can have is to nurture our intelligence in Africa. That's the only way to move forward. We can't eliminate poverty without education and training and improvement. And that's what this workshop is all about. We are well supported by a consortium of patrons. Lord David Alton is the chief patron of Motec and has been very influential and very supportive of what we do from the House of Lords. There are local names that you might know from the country who also support Motec. A couple of years ago we had Brasibre, people out in here, and last year we had Mrs. Marian Bano, who was very supportive of the presentation of the pulse oximeters. We got a bunch of trustees, so we work strictly under the guidance of the Charity Commission of England and Wales. We can't do things just by doing it, but we have to follow rules and regulations. So those are some of the people involved in the work of Motec. Members all the time. He's amazing. Of course, our TV journalist with us today, Dr. That's how it is. Members do travel. Many and in training in Ghana. The workshops who support us in some way. Okay. A series of photo showing activities that were begun. We have experts who try to solve some of the tasks she working for life in Jirapa. We share our experiences with the resident doctors from the institutions who join us at Kosovo. From commanders, from all the teaching hospitals. We do run training programs for the West African College of Surgeons in Ghana, at Togo, and Nigeria, from Motec. There is an Atom Center, which some of you know in Accra, which we provide regular lectures in the workshops. And of course, we do work with you. We haven't forgotten you. So you can see some of the pictures from, I think, 2011 or so. We have supported Leicester Hospital in trying to improve their care. You see in Koko teaching coming up. The teaching usually is split into two groups. One half of the hospital takes a day, and the other half takes the other day. New Life, which stands for Nutrition Working for Life, is our key project. Jirapa is one of the centers that we have fallen in love with to try to help malnourished children. We work with the local chief, the MP, and the hospital authorities to try to help malnourished children, their mothers, and the fathers, and the community as a whole. The very first workshop we did was at Peri-operative for the ambulance service. Press on the need for the better emergency services in the country. In a small way, we support teaching hospitals, especially the new teaching hospitals, Cape Coast, Tamale. The other places that we work and teach and share experience include Pramso, Jachi, Dunyana, Shanti Loji, Jirapa, Nkoko, Koforia. We have a link with Hohoi. Policies are influenced the way to help the whole country. The pictures you see are from the paramedic workshop at Koforia in 2008, which was well participated and quite enjoyable. We of course give certificates for participants. We do support some of the nursing staff and doctors to go for training. The first batch of nurses from Sifi Asafo, which is one of our centers, and Kofrodia went to India in 2010. They received training in many aspects of healthcare. And we don't just dump them there, they go along with one Motec volunteer from UK to support them. The hospitals that doctors and nurses from this country get training in the UK include St. George's Hospital in London, People Happening, and of course, my own hospital, Hertfordshire. So in brief, that is Motec in motion. That's what it's all about. Sharing experiences with you, which may bring improvement to people. We always say we want to invest to help our children's children. But as a matter of fact, the little improvement that we can make can save people today and can bring about improvements tomorrow. Not waiting for our children's children, but we can enjoy the improvements ourselves in our own lifetime. Thank you.
Dr. Foriata, the leader of the Motec Group UK. Thank you very much for the presentation, and we are happy to have you facilitating our programs. I think we'll invite Jane to give us something small.
Thank you again for coming along for this our third workshop here with you at CON in Ghana. We will have more delegates arriving as the week progresses, and as the day progresses, people are still coming to join us, and that's fine. Now, those of you that have not been here before will, I hope, be in for a treat. We will have some lectures delivered by experts in their field. We will also have some work for you to do, because the whole objective, as Paul has just mentioned, is for us to give you some information and for you to think, I like that, or I could use this, and put that into my practice to help my patients in my own hospital. Yeah? So the whole objective of this week is for us to deliver you what we consider to be our best practice, for you to be able to select items from it that you would like to take back and work with. Okay? So, a few bits. I'm going to need to keep dashing back this way, I think, to my slides to turn over. And, very much quick slides here going through. So last year we asked the delegates, we split you into regions and asked each region to present back to the whole group a topic. I'm not going to read through it all, you can read that for yourself, but these are the topics that they chose. So I think that actually does give the essence that the delegates last year recognised that they wanted to improve patient safety. They wanted to make sure that complications were minimised for their patients. And they actually said that they wanted to take forward teamwork, communication, ECG interpretation. Yeah? There's an interesting one there as well, which I'm sure that Ray will tell us about if you want to know. Honey dressing and maggot-eating swamp. Who surgical safety checklists were also something that we spoke about, and deep vein thromboses. You will be asked to fill out an evaluation sheet, and it's from those evaluation sheets that we create the next programme. I'm going to tell you a little bit more about that in a second. But from the evaluation sheets last year, we actually found that the delegates wanted to engage. They felt empowered to go back with enthusiasm and put change into place. We did touch on last year consent, participation. It's not us standing up here lecturing you. This is going to become, fairly rapidly, a two-way communication street. Alright? So, yes, you have come here to learn, you've also come here to share knowledge, and we're going to try and facilitate that for you. We also received from the AAGBI very kindly donated life boxes. These were pulse oximeters, and we had 10 in total last year that we were able to provide to hospitals in need, and we have another supply this year. We should, by the end of our trip out here this year, have ensured that there are in the region of 300 life boxes now in the country being distributed. There's a conference taking place this week for nurse anaesthetists, and many of them will be actually taking their life box back from that conference. Okay, so that brings us to 2013 workshops today, now. Have you all got a copy of the programme? Yeah? Brilliant. We're going to, despite your numbers, stick to the programme. For reasons as Paul has mentioned, we are a fairly big group, but we are spread across multiple different sites training. And we can't actually alter other people's schedules in order to accommodate the challenge that we have here today. So we are going to stick to the timetable, but if people arrive and they need to know more information, we'll make sure that the presentations are available for distribution. All right. Joel, would I be able to let you have those? Lovely, thank you. So, having seen the programme, does anybody have any other objectives that you would like us to meet? Anything specific that you'd like us to cover? Huh? If you think of anything, we're going to have a page on the flip chart here. Just add on to, what should we call it, objectives? Yeah? Anything extra that you want to know about, and we'll try and cover it the very next day. We've introduced most of ourselves, but whilst Paul was talking, we had two other members of our team arrive. Gina, can I ask you to come and introduce yourself, please?
Morning. My name is Gina Buama. I have a long name, but I'll just give you Gina Buama. That is the easiest one for you. My role is specialist community practitioner in public health. So today I will be delivering some of the lectures, leadership and management, and change management and teamwork. Thank you.
And back for another year, we have Ray.
Hello everyone. How many of you were here last year? I can see only one hand, so it means that all of you are new to this workshop. My name is Dr. Raymond Ofori. I work in the microbiology laboratory at Imperial Healthcare Trust in London. My specialty is infection control and infectious diseases. And I'm here to support the program. You will see me here on Wednesday with Jay, yeah, okay. So enjoy and participate. As Jane said, it's going to be interactive. We need input from you. At some stage, you'll be divided into groups where you're doing some group work, where everybody will be involved. So just enjoy the program. Enjoy the workshop, because there are quite a lot to learn, and also a lot that we can also learn from you. Thank you.
Thank you very much, Ray. Okay, I told you that participation was about to start. Nice and easy. I'm going to work on a show of hands. Ray's already started that. How many of you were here last year? Is it just the one person? Oh, we've got some more, Ray. Hey. 1, 2, 3, 4, 5. I need someone to scribe this down, actually. Nick, would you mind describing that down for me? So 5 were here in 2012. Thank you. Okay, you can see the questions I'm going to be asking. Who is a theatre nurse? Nobody. 1, 2, 3. Oh gosh, more. Oh, come on, I need, keep your hands up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Okay, 14 theatre nurses. You're there, 15. Okay, who is a nurse in recovery? 0. It just, the reason I'm going through this, it helps us to challenge how we are approaching our delivery to you, right? How about nurse anaesthetists? Is there any nurse anaesthetists here? I bet they're all about. Sorry, Nick. Nick's a senior consultant anaesthetist, so we were hoping to do some fairly intensive work with a nurse anaesthetist, but they may be here any other day. So, any managers here? Yes. 1 manager, 2 managers, 3 managers. Welcome. Any specific area you work in? Surgical ward. So, surgical ward manager? 2 surgical ward managers. Any other managers? So we have a surgical ward nurse here as well. Any other managers? Okay. So that gives us a good idea of who is here. But that doesn't account for all the people that are here. So, the rest of you that haven't put your hand up yet, what do you do? Right, so we've got some ward nurses coming on. Yep. Anybody else? We double most of ward nurses. Okay. There's a question I haven't got on my board. So those of you that double up as theatre nurses and recovery nurses, hands up, show of hands. 1, 2, 3, 4, 5, 6, 7, 8. Okay, what's done is helped us to get an idea of your role models. Already my mind is thinking, wow, you've got some intriguing roles here. You're working in a ward and needing to go into theatre. So what's going to happen when you're in theatre to your ward patients? You're working in theatre but needing to go into recovery. So good that you're following a patient through, but what happens to the next patient being prepared to go into theatre and the tidy up in the theatre? So I have these questions now starting in my mind. So I'd be intrigued to have conversations with you as the week progresses. You're going to have me here the whole week. On Wednesday, we have a very important day. Wednesday, we have the senior managers coming. The senior managers have been invited from all of the hospitals in Ghana, and we know that a fairly large number are expected here, and that's on Wednesday. They won't be in here, but they may well come in the afternoon after the lunchtime period to join you. Okay? But I'm going to be working separately with them in another room. We're doing a seminar session for them. So you've got a lot of interest. The slides I've shown you already show that last year's felt empowered. They felt they were given information that they wanted to take forward to put benefit for their patients. What we also heard, and I didn't put on the slide, was that they have restrictions, and those restrictions are their managers not knowing what we were covering here, and that was then sometimes difficult to go to their manager and say, can I change the practice, can I put this into place? And that's why we've invited the managers along. So they're going to hear what you're hearing and just making it very succinct for them. Okay? Okay. So, I have had tremendous honour the last 3 or 4 years meeting many, many Ghanaians, and I feel very privileged to have done that. So thank you for enlightening my life and giving me knowledge about a population who are very friendly, who are caring, and have a very wonderful personality. I take that home with me when I go back home to the UK, and Paul and I converse quite frequently, and I'm always itching to get back out here again. So I'm out here for 2 weeks this time. This week down here with you, next week up in Jarappa. But every year I go away and I think, well, I've learned quite a lot, but I want to know more. So I said to Paul, get me a map. He got me a map. So now I know what the regions are, okay? I've got some very good place names on here as well, most of which I am now starting to recognise. Well, I'll say most, probably about 20%. But it might get better. I can't pronounce all the words, and I'm very sorry I can't pronounce all of your surnames, but as those of you that have been here before know that I make a darn good attempt at it, but I normally need bailing out. So I apologise if I say a name incorrectly, it's not on purpose. But the reason I show you the map, I want to know more about you. So I've got a pad of paper here. I'd like you to take a sheet of paper, one per hospital. Paul, thank you. And on that, if you could pop over the slide for me. The slide will come. On that piece of paper, I need your region. I can then plan out where are you from on my map. Okay? So number 1 is your region. Number 2, the name of your hospital and the city or town that's the closest to it. That will help me to think, are you near a big area that we're covering serving, or are you actually out in the sticks and we want to do something very special for you? Could we just go back one slide? Hands time again. Joel, where's Joel? I'm going to need your assistance here, Joel. And I need a slide, please. Produce something that is going to be unique to your region. Now, I have a little bit of a panic in my mind, thinking on our numbers here today, that this might not be possible, but let's just see how we are in terms of regions. Joel, would you be able to go through the regions and we can just count, show of hands, how many people we have from each region?
Thank you. Upper West region.
2.
Yep. Central region.
No, 4 of you.
Where are the
I
others?
see 2 hands. Okay, they're
Upper
getting
West.
here, so
4.
Upper West is 4.
Volta.
1.
3. Volta.
So what that now tells me is that we can go ahead with our expectations on the programme. Northern region, I suspect, will be coming to the Jarapa sessions next week, so that's fine. If they don't make it down here in the next couple of days, that's where they'll be. So, as you'll see on your timetables, we need to have time in the afternoon for you as delegates to be able to feed back some information. We've actually already allocated certain days for that, and I think we can probably go ahead. So Tuesday we were looking at Upper West, up here, Central, and Bromahapa. So for tomorrow afternoon, we'll help you with this afternoon. You will need to give a 15-minute maximum presentation. Okay? I'll tell you the topics in a minute. On Wednesday, we have Upper East, Volta, and Western. Like the same, after lunch, 2 o'clock, 15-minute maximum presentation. And Thursday, we have Ashanti, Greater Accra, and Eastern. If anybody arrives from the north, they'll also be included into that. This will be time kept very strictly, so nobody can overrun. But equally, if you, and there are some of you are very small numbers, if then you need a shorter time, that's not a problem, you're not going to be penalised either. Okay? What are your topics? I hear you asking. They're up on the board. You may choose from one of those 4 topics, A, B, C, or D, and they're quite small, aren't they? So, A, demonstrate how you will convey learning from poll workshops to a wider audience. So how are you going to take what you're learning here this week back to your area? What are you going to do with it? How are you going to disperse that information? Yeah? That will that you will have to think of questions or comments as we go along. Start jotting them down, and your evaluation forms will be coming to you in due course. Why are we going to prepare our patients for theatre? That's good. That's a good summary. For the start of this session, good going. Okay, let's move on. We're going to identify health needs prior to the patient coming into theatre. If you can, prior to their admission, so much the better. It's useful to complete your investigations and get the results before the patient's in theatre. So working ahead of schedule is good. Plan the anaesthetic, nursing and the surgical needs. That's important. We can tell the patient how long they're likely to be in hospital, which you do, but not compromise patient safety. That means maximising the capacity of patients that come through safely and meet the demand. We spoke about informed consent at detail last year. Now, knowing that there were quite a few of you here that were not here last year, if you need that to be discussed, please get that onto the notice board. Consent is an important factor that we need to make sure you're fully aware of. Anxiety and fear, you spot on, plot that out straight away, and that's crucial. Patient's anxiety and fear is met. Okay, this is a slide I took a couple of years ago for patients in one of your wards. Yeah. So So in terms of patient preparation, we're going to talk through and walk through what you need to do to prepare your patient. History is number one. Yeah? We need to have an effective history. I'm going to cover that in a very small way, but it's going to be covered in more detail shortly. Physical examination is important. Observations for your patient, investigations, and check the results and action. Anyone disagree with that? No? Okay, brilliant. Don't forget the last two bits, prepare the next step. What's going to happen when actually I don't have you here to ask a question or to help me out? So identification of your patient. What question will you ask of the conscious patient to confirm their identity?
The name and the type of therapy. What is the word nurse who brought the patient to you? After the confirmation, you check on the folder and be sure that that's the same patient she's talking about, and the procedure the doctor wrote that is coming to be on that patient.
Righty-ho. Great as far as it goes. I'd like a little bit more on that. Any other thoughts?
The relatives of the patients are around, you can ask them the name and the other issues that you need.
Lovely. Excellent. That's some more information. So we're going to go through the relatives as well.
As she said, if relatives are there, inquire from them the name of the patient, then you cross-check with what is on the folder to ensure that you are dealing with the right patient.
Yeah. Indeed. There's something else that I'm looking for.
Confirm with the folder permission.
Alright, so you're all telling me about confirming with somebody else who that patient is, with the admissions, be it with the relatives and so on. You can see there's something else niggling up here.
If there is an identification label on the patient's leg or arm, you confirm with the name there.
Spot on the lot. ID bands. How many of you use an identification band? Not many. Do you think you could use to help mark your patient so that you know that Mrs. Jones is that person in that bed? What can you use? How can you mark the patient without using an expensive identity band? You can use a plaster, a zinc oxide tape or some elastoplast, something like that, on the arm or on the leg, and you actually write the patient's name on that. Yeah? You could use zinc oxide tape and put a piece on the back so that it makes a band, yeah, so it doesn't stick to the skin, and then you can write on that the patient's name, age, allergies, yeah. Coming along, sir.
Now there is some kind of use called bandage. There's full bandage, the plaster, that basic that doesn't come into contact with the patients.
Okay, for those of you who didn't quite catch that, at this gentleman's hospital, what they have used is a bandage on the arm and then some tape over the bandage so that the adhesive doesn't touch on the skin, which will also work. Anything that you can do to actually secure that you have identified the patient when they are conscious will help your colleagues further down the line when that patient becomes unconscious. All of you are dealing with patients who are unconscious, either through an anaesthetic or because of some other means. Yeah? When they're having an anaesthetic, you need to know who that patient is just as much as you do when they're on the ward. Okay? I don't know the figure because I don't think it's ever been kept in Ghana, but in the UK there's a very large number of near-miss deaths because of drug errors, and those were due to the patient being incorrectly labelled or the labels not being present, so drugs being administered incorrectly. And we don't want a single one of those patients to die because we've not identified our patient correctly. Okay? So yeah, I'm labelling this point a bit, but it's for a valid reason. Okay. Last year I'd been busy the day I arrived with a lovely mosquito bite in my arm, so it should make life really easy to be able to say, that's the area. I haven't been bitten yet, thank goodness. It will come. So, assuming I have a problem up here, how are you going to mark so that it's obvious that that's the site for my surgery? It might be you can't see anything on the skin. I don't want to come out from my operation having had something done on this arm, because that's where I've got the pain. How are you going to mark?
You can use a permanent mark or plastic, just a small thing.
So permanent marker pen. It's only permanent for 2 or 3 days. And you mark it with an arrow. Yeah? A big arrow. Marking the site of the surgery. Not a cross. Cross might mean don't go there. So it's always an arrow marking the site. Yeah? Indelible ink pen. Marker pen. You're going to find that we cover this a couple of times as the day goes on. So whatever you've done to your patients in your expert patient nursing care, you need to make sure that everybody else can read that information to benefit from it. So the patient isn't being asked the same thing over and over and over again. So your writings must be clear. They should be in black ink. Black ink lasts longer. It photocopies better. So it stays as a record for a much longer length of time, rather than blue ink. All of your entries should be legible, dated, timed, signed with your name, because you made that entry. As a nurse, you are accountable, are you not, for your actions and your inactions. So take ownership of what you've done well, and ownership of what you haven't done well, but learn from it. So you're going to sign everything you've done, and make sure that people know how to contact you. Now about the history of your patients. So what history would you like to know about? How many family members they've got? Like over holidays? What history do you want to know about their patient?
We'd like to know whether he or she has had a previous surgery or any allergies.
Yep, past medical history, surgery, and any allergies. Anything else you want to know about?
Well, based on what she said, I know the site of which she had been.
Okay, so site of the surgery that patients previously had. Any other history that you want to know about? Medical history. Sorry, medical history.
We also need to find out whether he or she has had a previous surgery.
Yep, previous surgical operations.
What I was doing, I feel like it's supposed to be.
Yeah, so any anesthesia before, they might have had surgery under a local anaesthetic as opposed to a general anaesthetic. Any other history that you're going to be interested in?
On the name, medication.
Medication, coming up twice over here. Anything else? Coming down. Spot on. Looking at their social history as well, so any alcoholism, smoking history, drug abuse, yeah?
Any complication from the previous surgery?
So past medical complications or surgical complications resulting from past history. Excellent. Well done. Have we missed anything? Have we missed anything? I think we have. Let's find out. Presenting complaints. Why are they coming in? Their surgical history. Anaesthetic history. Any intubation difficulties? Patient might not know about that. Nick is going to be covering airway assessment and complications later on this week. Medical history, particularly important, sickle cell disease. Respiratory history. You have far greater number of respiratory cases here than in the UK. So respiratory history is very important. Cardiovascular disease. So there's a lot there. You've also implied, but not specifically mentioned, other health disease, such as epilepsy, diabetes. Alcohol, drug intake, yep, you've covered all of that, which is brilliant. Drug history in the terms of current diabetics or steroids, which could well affect how the patient progresses through their operation. And again, I'm sure we'll be covering on patient's medication and how that affects the anaesthetic in our anaesthetic sessions. ACE, I'd say we probably got 9.5 out of 10 for that. Well done you. Excellent. Excellent. Okay. So, I've got a question coming up for you. What are you going to look for when you observe a patient? What are you looking for when you're observing me? Okay.
How tall you are?
How tall or fat you are? Yes, absolutely. Yeah. So the size, the shape of the individual.
Your appearance.
Appearance. Would you like to be more specific on appearance?
Maybe your gait.
Yes. The way one walks. Yeah.
Physical
Physical appearance. Okay.
When you are standing, I look at your posture. Whether you are standing tilted, I look at your facial expression, whether you are in pain.
Excellent. So what we're coming at here is what you're interpreting from what you're observing, yeah? You're observing posture, gait, weight, height, appearance. Does somebody look clean? Do they, is there an odour? Sorry, someone behind me then. And you're interpreting from that information. Yeah, so you're interpreting, is this patient walking in a difficult manner so they're in a lot of pain? Do I need to do something very specific for them because it looks like they've got maybe a problem with the hip, a hole in the hip there? So that will actually lead you to start thinking about other questions you need to be thinking of. What else are you going to observe about that patient? Are they clammy? Are they sweaty? Could be a sign of diabetes. It might just be a hot day, but it could be a sign of diabetes as well. Are they breathless? These will then link your mind to be thinking, I now need to be very careful about my respiratory assessment. Yeah. Very, very careful in your observations. It looks like you all are, but you're all very attentive. you will actually be taking a lot of information, processing a lot of information about what you see about the patient, interpreting it in your mind and thinking, aha, that could be X, Y, Z. The build of the patient, you brought that one up. Are they obese? Are they malnourished? The checking. Do they have Marfan syndrome, Down syndrome? Because patients who have these syndromes can have abnormalities that we need to look out for. Some of them are hidden. So a patient with Down syndrome could well have restricted neck movements, tend to have a very short neck. They might have cardiac problems. Okay, you keeping up with me? Anyone struggling at the moment? No. Brilliant. Okay. So we looked through the observations. We started looking at general appearance, hands and face. Are they sweating? Do they have clubbing of the fingers? Do you know what clubbing is? Clubbing of fingernails? Yeah? No? No? Right. Fingers together. You'll actually see that the fingernails should meet the top. Yeah? You did that. In clubbing, the fingernails go away from each other as per the bottom picture. So this is the top, this is the normal nail bed. There's the nails, they go up together. In this view, this is the clubbing, the nail is going away. Yeah, so you get that V-shaped formation. Anybody know what causes clubbing? Information on this one. I'm not aware of the full cause, but it's hypoxia in the body, long-term hypoxia. Once the patient has clubbing, it never goes away. But that's a clue for you as a nurse to think this patient may have low oxygen levels. Yeah? I've got to be careful. Good. So far, we've gone on to history. Find out why they were coming in, what's wrong with them, what their past history has been. We've observed our patients, and only now are we going to come on to examine our patient. And we're looking at a pulse. How many of you now have electronic blood pressure machines? Any of you? No? Yeah? You use electronic machines. And electronic machines record pulse and blood pressure. Some of them do oxygen levels as well, don't they? How reliable are they? They're not taking it manually. Okay? Radial pulse. Yeah? Don't forget your training, radial pulse. When you're recording a radial pulse, what are you looking for? What do you feel? The rate and the rhythm. So rate and the rhythm. Yeah. Electronic machines do not pick up rhythm. They might pick up a rate, but they don't pick up rhythm. Why is a rhythm important? Somebody else's turn.
It's a regulation of how the heart is beating. It's a regulation of how the heart is beating.
Yeah, it's a reflection of how the heart is beating, yes. I'd like a little bit more information, that is accurate, no, 100% accurate. What? Yeah, rhythm is a stage of the heart, yeah. In particular, is there a type of rhythm that would worry you? eating rather like that fan is. Is that okay? Yeah? No? You'd not be happy with that? Regular? Yeah? So are we all happy that that would be okay? Yeah. If it was not regular like that, would that be okay? Oh, it wouldn't. Irregular heart rate says the heart is pumping irregularly. Why? It could be a multitude of questions and reasons. An irregular heart rate could mean that that patient might develop a blood clot more readily. It could mean that they have atrial fibrillation. Blood is sitting in the heart longer than it should do, and it has the opportunity of congealing. Yeah? It's not pumping through the heart regularly. So we worry about an irregular heart rate. Irregular heart rate, as soon as you feel that, what's your next thing you're going to be wanting to do? So I've just felt that that patient's got an irregular heart rate. Your mind has straight away said, I need to do an ECG. How many of you have got an ECG machine? Not many? No? Is that seriously, is that a problem? Whoa. Okay. I'm back in my audit mode. Can you see how questions and answers actually get your brain thinking about other things? Let's have a show of hands. How many of you have easy access within, say, an hour of an ECG machine? Okay. Is that just in theatres? So it's not many. How many of you have no access to an ECG machine in the areas that you work at all? Okay, thank you very much. It's a very low volume, it's not bounding. It will suggest that the patient might be in shock or hypovolemic. They've not got a good circulating volume of blood. Dehydration, I would suggest, might be a common cause for that locally. What we're looking is for a patient to be relaxed before you take a blood pressure reading. That you apply the cuff to the correct part of the body. Usually, commonly it's the upper arm, but it might be the thigh. The patient who's had multiple trauma, or you have no access to the arms for some other reason. That cuff should be carefully positioned and the patient relaxed. If while I've got the cuff on, my arm is bent, I'm moving my hand, flexing my arm, tense, talking, all of those things are going to give an abnormal reading. Okay? Keep your patient relaxed. I'm not going to deliberate on this particular observation chart, but this is one that is used fairly widely now in Europe. This is called a National Early Warning System score. It's an observation chart, which, as you can see, is colour-coded. So the white area is no problem, but if the patient's scores go into the red area, then alarm should actually be bringing in some assistance to come and see to that patient. Yeah, so it's a visual score as well as a written score. Fingers. Note these two are down. Do not use these two. These two are fingers that we use to pick things up with. Diabetics have major problem with neurological problems, neurological movement, sensation. So if you use these two fingers, over the years, they're not able to pick a pen up to write. pick a piece of paper up, open up a packet to eat. Yeah? So only use these 3 fingers. Okay, what part of those fingers am I going to use? What part of those fingers am I going to use?
Sides.
The sides of them. Yeah. Never, ever, ever use the pad. Never use the pad of the finger. Yeah? So only use the sides. And when you've got a diabetic patient, they have regular glucose checks, don't they? So use one side each test, and then you can rotate round again, okay? Can you take that very important message back to your teams? That's one thing I will be prescriptive on. These 3 fingers only. Save your patient for the diabetic. Okay, what else on that? Unless anybody wants me to, I'm not going to cover anything else on that slide. Are you happy with that? Brilliant. Okay, we'll go. Okay, now there will be complications potentially for patients who have medical history about a patient who has epilepsy.
Well, first of all, ask the patient if he knows what is epilepsy. Yeah.
Okay, so what type of epilepsy? Yes. What else are we going to ask this epileptic patient?
If the patient confirms that he or she is epileptic, we try to find out in an attack, how long does it take? And or you ask from relatives, because at times the patient might not be able to tell during the attack the period.
Okay, yeah. So we're going to find out a little bit more about the history, possibly from relatives. Any other specific questions we're going to ask?
As to whether he knows the signs if the attack is happening.
So the patient might have an awareness that it's going to happen. Yes. Anything else? Oh, Johnny. The frequency. How often do these attacks occur?
Is the patient on any medication?
Any medication? Same question. Any medication the patient takes. We try not to stop medication for epilepsy prior to theatre. Okay. Try to maintain a normal medication. I'm sure they will cover all about that. Medication, theatre, anesthesia, mental speeds. One other question I'd like to know is when was that diagnosed? Thank you, sir.
Thank you. So I don't know what triggers the attack or affected that.
So what triggers the attack? Because occasionally stress might be the trigger factor. And we're about to put this patient through a pretty stressful time operating on them, taking away their consciousness and looking after the patient for them. And that scares a lot of people. So an attack could then be anticipated, triggered. So when were you diagnosed with epilepsy? Do you know what type of epilepsy you have? Are you on medication for it? When was your last attack? How well controlled are they generally? Yeah. So those are the sort of triggers. If the patient has a sensation, has an awareness that they're going to have an attack, get that information down as well. Based on whatever it was that we have found. So we're going to investigate, and that will actually give us some more information that the team are going to need. You're now expanding from what you have done to a wider audience. So the doctors are going to want to come in and look at the patient. They're going to want to see what you have found out about them. The anaesthetist is going to want to come in and see what you found out about them and what the doctor has found out. They're going to want to look at the investigation results, that ECG, if you were able to get one. The fact that you found that the pulse was irregular is important. You need to have a mechanism to flag up, this is an abnormal reading, flag it up the line straight away. Yeah? What else do I want to pick out from that? You may want to refer the patient to an anaesthetist or to your medical teams quickly because you picked up something you're worried about. A very rapid heart rate or a very low oxygen level. You may want to give some information to the patient about the procedure, about their recovery period, and you certainly will want to make sure that they have signed a consent form before they go to theatre. The surgeon should be the person signing the consent form because he is the person who knows what he's going to do, he or she, and therefore the risks and the benefits to the patient of the operation. Okay? So a surgeon should be the person that signs that consent. And the consent should be signed in sufficient time that the patient has the opportunity of thinking through what the risks and what the benefits are of that operation, what are the alternatives, before they go to theatre. So I can see a question coming up.
Yeah, I have a question. Did I hear you say the consent form? You say them who have signed the consent form? I'm playing the devil's advocate here.
Yeah, and that's fine. That's exactly why I'm raising it as well.
Because I know that when I went here, the consent form are signed on the wall by the nurses. Unless it has changed, I don't understand what
it's changing.
it's changing.
We gather that there is a consent form being rewritten and is going to be distributed across Ghana. But the best practice is somebody who knows what the operation entails, what the risks and the benefits are, should be the person to sign that consent. So the ideal person is, as I say, a surgeon or a surgeon capable of the procedure. There are, as with everything, exceptions. Now, as a nurse, if I was working on a ward and a doctor came up to me and said, "Oh, get that consent for Mrs. Jones going to theatre," I would say, "No, sorry, I don't know precisely what you're going to do, what you have found in the results of the investigations and what the risks are to that patient, etc. But I do know that your practice here is very much that you are put into that very difficult situation." One solution that we have come up with in the UK, and you might want to think about doing something like this yourselves, is actually having nurses who can take consent. So if there's a procedure, I'm going to take cataract operations, which is a procedure where we know what the risks, what the benefits are, we can be fairly prescriptive of that. The nurse will be trained to take that consent. They should actually have some training from the surgeon who will say, when I'm taking consent, I will go through these risks, these benefits, these are the complications. And the nurse learns that, she's examined on that, as in the surgeon will observe her taking consent on several occasions, and the surgeon will then say to this nurse, "I'm happy with what you've done, if you keep doing it like that, then you can take consent for my patients." So they then have something in writing from a surgeon to say, "Yeah, you can take consent for my patients." Yeah? It's a competency that they learn. And that means that legally think that nurse is covered because she has a competency training piece of paper which says, yeah, I've undertaken training for writing consent for patients having cataract surgery, signed by consultant surgeon Emerson. Okay? So that's how we overcome that one in the UK. So the investigator goes through ECG and look at the results. There may be some radiology if there's respiratory disease. Okay. Just to let you know some interesting facts about diabetes. We've just had results of, in fact last year, 16 studies were analysed, a meta-analysis is called, looking at sub-Saharan African diabetes risk. The population of sub-Saharan Africans, Afro-Caribbeans and of South Asians have a 50% increased risk of diabetes, irrespective of where they live in the world. So there's something in the genes that unfortunately predisposes you to diabetes. So consider that a random blood glucose level should be undertaken in a large number of your patients, if not all. The rather more worrying factor is the next one down. So post-menopausal women have a 27% increased risk of breast cancer. So please make sure, ladies, that you do your breast checks regularly every month and keep an eye on your signs. Is breast education undertaken for the population? Are people made breast aware? Do I take that silence as meaning no, you don't get the education on breast awareness? There is some. Good. Okay, that's great. Brilliant. Okay, you got it. We don't think that it's linked to overweight. We don't think it's linked to body mass index or high carbohydrate intake, but they can't prove it, but they think there's probably a genetic disposition. Okay. I'm not going into any of these details at all. I just want you to be aware that infections on the surgical site far increased risk of infections if the patient is of advanced age. They've got a poor nutrition. They have colonisation of microorganisms, so the skin has not been kept properly. They have a coexisting infection at another site, and so on. Ray, is there anything else you wanted to add to that? We are covering infections on Wednesday. Brilliant. But many of you work in theatres and recovery. Please note what's up on the board. Oh, it's gone. Come back. Surgical site infections. So there's infections occurring at the site of surgery. Inadequate skin preparation. So think about how do you clean the skin, how do you prep that skin even before the patient gets to theatre. Has the patient had a bath or a shower or a wash of that area? Are there any abrasions on the skin where infections can get in? From the surgical team themselves, and that includes, as we are teams, the nurses, the anaesthetists, and the surgeon, and the OR staff, everybody, have they all donned the correct garments? Have they removed earrings, necklaces, nail varnish, etc., watches? Have they actually washed their hands thoroughly? Yeah. We covered hand washing in detail here, I think it was last year. If you want me to go over hand washing again, I can do that on one of the other days. It's not currently programmed, but I'll do that if you want me to do so. Inappropriate surgical attire drapes comes up there. So, if the surgeon or anybody who's in theatres is feeling peckish, the last thing they should be doing is walking out of theatres, down the corridor, into the canteen to get something to eat. Yeah? Always change. And I've seen nothing but good practice from that viewpoint, which is brilliant, but I'm just bearing it in mind. We always get reminders in the UK, make sure that you remove the theatre gowns, etc. before going out to canteens. Excessive duration of operation is up there, so when the operation's gone for a lengthy period of time, those patients are more at risk of getting an infection. We know that as a fact. Surgical technique, there's excessive blood loss, hypothermia, trauma to the tissue, then again there's an increased risk of infection, and inappropriate use of antibiotics and antimicrobials.
It is when blood clots in the cardiovascular system or in the blood vessels, and they go and plug somewhere in the respiratory tract. They go there. They cause embolism.
Brilliant. Okay, thank you very much. So, venous thromboembolism is where there is a thrombus in the venous system normally. Commonly, they occur in the leg, distal, below the knee, or proximal, which is above the knee. And they tend to occur when we're not moving very much, when we're dehydrated, when we're obese. There's an increased occurrence when we're older. And your patients going to theatre are laying on the theatre table. They're not moving. The only thing that's going to encourage blood to be circulated back up is every time you move a limb. Because normally, what are you all doing? You're fidgeting your legs around a bit. You've sat down long enough. And every time you're moving muscles, your muscles are contracting and they're pushing the blood up through the veins back into the heart and circulating it, yeah? Your patients on the theatre table are laying there and they have muscle relaxants, so they're relaxed. So their blood is stagnant, virtually, up where the heart's beating, but it's actually not moving the blood around in the way it would normally. So they're at greater risk of developing a blood clot. Up on the board, you've got the risk indicating factors. And there are things that we can do to reduce a blood clot forming. One of those is applying stockings to the patients. I'll pass these around for you to have a look at. It's actually knit tube. No, I'm not going to put them on myself, either. Not right now. So, these stockings are below knee ones. They have a heel and they have a toe section. Some of the stockings come with a hole at the top here, and patients like to put their toes through, which is a bit cooler, but actually they shouldn't, and that's why more modern ones are now coming sealed at the top. But what's important is that you get the heel in the heel bit. And then the rest of the stocking is graduated with elastic, which puts pressure on the calf muscle in particular to encourage the blood circulating back up the veins. Pass that one down that way. There are stockings coming around, so Plexane or loxapine, heparin can be injected subcutaneously to do the same thing. Their social history, their drug history. lots of history words. You've then examined, so you observed your patient, you've then examined your patient, you've ordered investigations. So you've made sure that you've got baseline observations and that they're recorded. If they're normal, great. If they were abnormal, you've reported them on. You're going to starve your patient for 2 hours for clear fluids, 4 hours for breast milk, and 6 hours for solid food. Your medication, you've recorded what the patient normally takes. There may be advice from the surgeons that they want some medication stopped before coming into theatre. And you have recorded down any allergies the patient has. I haven't actually labelled on allergies. Infection control, you strongly are going to make sure that patient is clean before they go to theatre, because you don't want to have post-operative infections. The patient should remove their own clothing and put on a hospital gown. ID bands. When are the ID bands going to go on our patients? When did you say you can put an identification band on your patients? As soon as the patient comes to admission, identification. Who are you? Age. Write it on the band, on the patient. Yeah, that band stays there till they go home. Do check them regularly, because if the patient washes, they can have a problem with the band, especially if you've had to handwrite it and just update the band. You want to know who's the next of kin. What after, despite all of our preparation, that patient needs urgent attention with their family because there's a problem, it's a complication. How do you get in touch with the next of kin? So you need that data. You need to make sure your equipment is ready and available in theatres and on the ward. You might want to make sure there's venous access. If you starve a patient, we said it's actually quite difficult to get a line in. So you will want to make sure you've got your venous access. You want to stop from getting a blood clot after surgery, so you're going to be watching out for venous thromboembolism, taking precautions there. And you're going to mark the site of surgery with an indelible ink. Yeah? Excellent. Well done. Okay, I think I'm going to hold it at that point. I gave you at the start 2 objectives. So you have a sheet of paper on which I need 1 sheet of paper per hospital to tell me a little bit about your hospital in your area so that I can actually find out a bit more about what your needs are. If you don't have an ECG machine, that's the place to put it, okay? I can't promise you, I can't get you machines, but at least it gives me an idea as to what challenges you have to function. And the other thing I said is, if you have any objectives, hello sweetheart. If you have any objectives that you don't think we're meeting, stick them up on the board, okay? So we're just going to do a quick handover. I'm going to hand you over to Amanda. Hello. She does on a day-to-day. Amanda, over to you.
Hello everyone, hi. Hi. I'm going to get off the stage because I've been given a microphone. I'm feeling a burning desire to sing. I'll spare you that. So thank you, Jane. As Jane said, I'm a modern matron. That kind of conjures up all sorts of images back in the UK. But basically, we are senior nurses and we are there to sort of guard patients' experience in our wards. My patch is the elective surgical patch, so I have the day surgery, surgical wards, and look after that patient pathway right from sort of pre-operative care right the way through to their discharge home. That in a nutshell is is what we do. It's about making sure the quality is there for our patients and that their care is safe. And my big thing is about driving improvement. What are we not doing yet that we can do better? So today, I'm just going to share with you some of the sort of systems and processes that we use over there, and sort of pressing home points that Jane made earlier around how we take history of patients. That's the lecture I'm kicking off with. We'll head into it. Jane's obviously covered a lot this morning already, so please feel free to shout at me, move on, Amanda, if I'm really repeating too much. But sorry, Jane. Finding patients. We talked about that quite a bit already this morning with Jane, but I just can't press home enough how important it is that what you do first with your patient around identification sets the scene for the whole journey for that patient. If we get things wrong at the front door, and in our hospitals that's an A&E department or our admitting wards, if we don't get it right and identify the right person, put them in the right place at the right time, the care is going to be wrong. Their management plan will be wrong, and the ensuing journey for the patient will not be a seamless quality experience for that patient. Jane's kind of pinched a few of my questions that I had planned for now, which was around kind of how you do identify your patients now. So there are some areas where you're using bands, tape, numbering even. Something we do back in the UK is we have patient identifiers. So we talked about asking a patient's name, their date of birth, we would ask their address, we would have an NHS number, so every patient has an identifiable individual number associated with them. When we're doing anything with these patients, drug administration, consenting to theatre, diagnostics, we are looking for 3 identifiables each time. So tell me your name, tell me your date of birth, tell me the first line of your address, and that's each time that we're administering medication or doing anything where we require consent. Clerking is another sort of important area we're going to focus on just now. Do you have a clerking process? What do you do for admitting? We've got some ward nurses here, I know. Anyone want to put their hand up and just talk to me a little bit about it?
With the personnel, the name, the age, the occupation, the house address, the next of kin, and the history, when the right.
Okay, so you have those in an admission form requiring certain information. And is that standardised? Is that something you do across your wards? Okay. So back in the UK we call that something like cardex, or back in the day we used to call it a cardex. But it's an admission pro forma, so it's a standard set of questions that you're asking of a patient, which will help you identify your patient, but it does help you understand more about your patient. We'll go into that a little bit in more depth in a moment. Process of admitting a patient. First thing we do when somebody hits our wards or front door of a hospital is band those patients. They get an ID band. That ID band identifies that patient, stays with them. It's a bracelet throughout their journey. But the other side of these bands, it does represent allergies. So we haven't really sort of talked about that in great detail yet, but identifying the patient's allergies, sort of catastrophic events around drug errors and things like that. History taking. Now you talked about your pro forma, your admitting documentation, but equally you need to go dive a little bit deeper, find out about the lifestyle of that patient. All helps build a picture so that we can create much more accurate management plans for how we go forward with those patients and their treatment. So the ideology bands, I think, probably pressed that home enough now. The identifiable markers, for us it's the name, date of birth. Understand date of birth is difficult, and address. Admission pro forma, we've got an example of one here. Something we're working on, or working towards back in the UK is pathway pro formas. So rather than a standard Cardex that's generic for all patients, we'll be looking for a pathway document which is more about the complaint. So if a patient was come in with, for example, a fractured hip, they go onto the fractured hip pathway. So it's a document that carries them through their whole journey. So it'll have their admission on the front, it will carry them through to their the ward care plans, theatre recovery, post-op recovery on the ward, and it's all in one document. And so you're not missing any element of the care, it's all there. Is there anything like that out here? Do you have anything like care planning? Do you have care planning, but it's all individual? It was a very, very multidisciplined approach to how the pathways were designed, and it again encourages multi-professional working in practice, in theatre, on the wards, in recovery. So it's drawing all those specialties and all that knowledge and expertise together to sort of inform and impact on that patient's admission. Their elimination, what's their bowel and bladder habits normally, what's it normal for them? And we'll go into that shortly as well. Past medical history, you mentioned it earlier, very, very important, relevant past medical history, because that may have an impact on what they're presenting with in front of you that day. So the patient interview, what I'm going to focus on really is the skills of how you draw that information out of the patient. Incredibly important in treating the patient is being able to build a rapport with your patient, gain their trust. Without that, really going forward and asking their compliance with their treatment is very, very difficult. Each person will have their own style and technique. Some more assertive, some more shy. Everybody's different. That's the joy of the work that we do. But it is about holistic care, and that's about treating the patient, not the sore toe or their aching tummy or their poorly eye. It is about looking at the whole patient and understanding that person. The better you understand your patient and your treatment plan will be, the better the outcomes will be for the patient and your own satisfaction. You know, I go to work when I go home feeling satisfied that I've done a good job that day. The only time I can do that is if I've got to know those patients and I know I'm doing the right thing for them. I mentioned patient compliance. We have naughty patients. I'm sure you have naughty patients as well. There's patients that just won't do as they're told. But it's how you get them on side. What skills can you adopt to get those patients on side, get their trust? Two really basic elements to an interview, and that transferable across interviews into work, life. For this purpose, we're talking about the patient interview. Sorry, the font's getting smaller. Can you all see? I'll read through. The setting, really important. How do somebody feel like we're protecting their privacy and with that their dignity? I'm sure that's quite challenging. It can be challenging back in the UK at times. But the environment is something we should be aware of. Are we sitting with the patient in the middle of a room with other patients? Have we drawn the curtains to create a screen? What are we talking about with the patient? If your patient's not comfortable, do you think you're going to elicit lots of information from them? No. Because they're going to be very anxious. You talked about the importance of allaying fears and anxieties. Well, the environment can have an incredible impact on that. Patients coming from home into a hospital environment, you know, it's a sterile, unfamiliar environment, can be very daunting, lots of activity going on, scary equipment around the place. You know, immediately, I'll be feeling tense and anxious. And you guys know that. So it's what can we do to really put that person at ease. Patient having rights. Patients do have a right to have a pleasant approach, for us to be polite, compassionate, caring. That's what this job's all about. And again, the environment really impacts that, how you set up a scene to take that information from a patient, interview patients. Thinking about, and again this will be difficult, but how could you adjust your surroundings? So how could you make that patient more comfortable in a very busy, hectic environment? Anyone got any ideas about that? So noise, that was reducing noise. And particularly problem maybe at night as well. You've still got lots of activity going on and trying to encourage people to sleep. And yeah, excellent. So you can screen the area, process. So the questions are really key to an interview. And a good interview of a patient, of anybody, would include a mixture of both open-ended questions and closed questions. Do you know what I'm talking about when I'm talking about open and closed questions? You're trying to find out something about me. What would be a good open question? Anyone have any ideas? Wow. Big question. Who am I? Okay, but that's a decent open question because I could ramble on all day about who I am, what colour my hair is, how hot I am, etc., etc. But a closed question then.
How's the family?
How's that? That's quite an open question because I could talk to you all day about my aunts and uncles and the like. Okay, I'm 21. But that's a closed question. So a closed question is a question that will elicit a yes/no answer, and that's it. So how old am I? Am I hot? Yes, I am. You know, these are the sorts of questions that we would call closed questions. They do not encourage vast amounts of information, but they're still necessary in an interview. And they're also a good way of guiding an interview. Patients will, there are some patients who will talk and talk and talk and talk, and they're a nice way of bringing the interview back around, you know, just give it a little bit of a steer. Any other examples? Questions, just more questioning. So,
to describe the kind of thing you want to do, you ask the interview how it feels like, instead of saying, are you in pain?
That's really good. So that was about finding out information about a patient's pain. So there are again ways of bringing a patient home the answer. So are you in pain? That's the closed question. Yes, I am. Or no, I'm not. But you want to draw some more information out from that. So as you said, you know, describe the pain. Where is it? How does it feel? Or you could start using scales to understand just how bad that pain is for that patient, because we all have differing tolerances of pain, amongst other things. But, you know, stick a scale in of 0 to 10. Where is your pain on the scale of 0 to 10? So, and using sort of fixed examples for patients to benchmark against can really help. So that was a great example. Thank you. Streamline all of that process. And that's something we're working on. But right now, we're still sort of using medical clerking and nurses admissions as well. But In brief, really, this is what we're looking for in medical clerking. So it's the greeting, who you are, asking who they are, setting out the expectation very briefly of what's about to happen. Personal history. So you said earlier, you mentioned earlier that you have this on your admitting document. So what's the age of the patient? What's their occupation? So those sort of facts around the patient. What's their chief complaint? There might be many, but what's the thing that's brought them to you that day? And how long has it been going on? What's the history behind it? And you may be forming your own opinions at this point, but we need to hear from the patient's perspective what they think has brought that on, where it originated, when, how long they've been suffering with it. It's really important. Past medical history, again, really important. So you want to know, as Jane mentioned earlier, you want to elicit that information about, are they epileptic? Have they got diabetes? Have they had a thrombosis before? That's sort of, you need to draw that information out. And if you have prompts on your admitting pro formas, you know that those questions are never going to be missed. That prompt is there for any nurse to ask that question. Drug history. I take the little white one every morning. We need to know what drugs they take. It's really important before we can start adding in anything else as in a treatment plan. So it's understanding what they take, if they take anything, what they may have been taking recently that they may have stopped. So it's not about just the here and now, it's thinking about what's been in the run-up to their admission to you, what's brought them to you. Family history, really important as well. So what's going on in the family right now? Are there any sort of genetic conditions that you might want to be thinking about? Lifestyle, that's where the ADLs come in. So our activities of daily living really help inform a picture around lifestyle. Do we drink 2 bottles of vodka a day? Do we not drink but we smoke like a chimney? We need to find out about our patients, and the lifestyle questioning will really help us do that, and that can help us form a picture. It is just a picture. It is not for us to judge or make comments on anything other than in a health promotional type of way, but it does help you build a picture of what's brought that patient that day, what their stresses are and anxieties are outside of that situation. Could have a go at a little bit of role play. Fancy a bit of role play? That'd be alright.
Good morning, sir. Really nice to meet you. Morning. How are you feeling today?
Not as well as I was yesterday.
Can I just ask you a name? Sorry.
Florence.
Oh, it's really lovely to meet you, Florence. And may I call you Florence?
Well, it's a bit personal, isn't it?
Would you like me to call you Mrs.?
No, Florence will be fine.
Florence, thank you. Nice to meet you, Florence. Can I ask you what's brought you here today? What's your chief complaint today?
Well, I've got a lump in my groin.
And how long's this lump been there, Florence?
Oh, a long time, dear.
And so why today? Why have you come today?
Well, it's getting a bit embarrassing, really.
And why is that then, Florence? Tell me about that.
Well, every time I laugh, this lump, it pops out. And, it's just a bit embarrassing, really.
Okay. Is it painful, Florence?
Yes, it is a bit painful.
Okay, and on a scale of 0 to 10, how painful is it?
Yesterday it was 10, but today it's only 2.
Oh, okay. And it's come today. Okay, and have you taken any medication for it? Or have you done any interventions so far?
Yes, I just have a little tot of whiskey actually when it's painful.
And you find that helps?
Oh yeah.
But you've taken no painkillers?
No, don't like taking pills, dear.
So on that note, Florence, have you any other medical history I should really know about?
Well, I had a heart attack.
Okay, I'm sorry to hear that. I'm glad you're sitting here now, but do you want to tell me when that was?
Well, I think it was about a year after my cat died.
Thank you, Florence. I'm sorry about your cat. Do you take any medication right now, Florence, since your heart attack?
Yes, I take the little blue ones and the little white ones.
Do you have the name of them at all, or a family member I can contact and find out?
Yes, you'll have to phone my husband.
We'll take that down. We'll take all that information from you shortly. And in the family, Florence, have you got anybody with similar problems or other problems you think are relevant I might need to know about today?
Well, lots of my family are dead, so you can't ask them. No, I don't think so. Nobody else has got a hernia.
I'm glad you know it's a hernia. Florence, thank you. Florence, you mentioned that you had a little tipple of whiskey. Is that something you like to do quite a bit? Do you smoke at all?
Oh yes, I like my whiskey. And yes, I smoke quite a lot as well.
Okay, Florence, we'll park that for now because I'm going to talk to you about that in a little while. Well, let's sort this hernia out then. I'm going to have to do a physical examination of you at some point, but I'd just like to get a grip of perhaps how this has come about. So, are you working at the moment, Florence?
No, I'm retired.
And any heavy lifting in your day-to-day activities?
Well, yes, I have to lift my husband. Actually, because he's disabled.
Okay, so you're chief carer for your husband. That must be quite stressful.
Very stressful. That's why I need the whiskey.
And that might be why you have a hernia, Florence, as well. Okay, so I'm registering all this information because I'm building a picture of what's going on in Florence's home. So she may be here with a painful lump in her groin. It's not so painful today. It was very painful yesterday. And actually, she's got an ongoing situation at home that's not going to go away. So that's not going to help. If there's any intervention required with the hernia, the problem at home still stays. So, okay. Thank you to Florence.
This headache started? Talking about 2 weeks ago. And when it started, 2 weeks ago, I did take does any of your children know?
Welcome to the General Hospital. I am Selena and she is nice to meet you. Please